Assalamu alaikum. I would like to welcome you guys to my presentation. The topic is Numerical Analysis for the Hemodynamics in Unruptured Cerebral Aneurysms. It is in collaboration with Tawam Hospital and the Mechanical Engineering Department in UAE University. My advisors are Dr. Mohammad Hamdan, main advisor, and I have co-advisors Dr. Waseem, Aziz, Dr. ElNajjar, and Dr. Naqbi. An outline about the presentation. I'll start by an introduction, and I'll talk about how we pre-process the image. And we have 4 objectives that we studied in our thesis, and conclusion and limitations, and future directions. First of all, let's start by defining what's a cerebral aneurysm. First of all, cerebral means it's inside the brain. So whatever is inside the brain is called cerebral. And an aneurysm is a thin and a weak spot on the blood vessel in the brain. And it grows. So basically, this growth could lead to rupture of the aneurysm, could lead to the aneurysm affecting other arteries and nerves around the brain. So it could lead to vision loss. It could lead to a lot of stuff. So this is what we are studying here, cerebral aneurysms. Some data. First of all, cardiovascular diseases are the 3rd primary cause of death in the world. And cerebral aneurysms are considered a cardiovascular disease. Also, an estimated 6 million people in the United States have an unruptured aneurysm. So it's unruptured yet. It might rupture, it depends. Yeah. One thing that is dangerous about this disease is that it has no symptoms. So anyone could have them. And research shows that it affects around 2 to 5% of adults. And it has around 500,000 deaths worldwide per year by aneurysms. Okay, so treatment procedures. We have 3 types of treatments. First of all, clipping. This is like the harsh part of aneurysms. What the neurosurgeon does is that he opens the brain of the subject and he digs in until he reaches the aneurysm. And then he puts a clip on the aneurysm. A clip, so it closes and the blood doesn't go inside. So this is the first procedure. Usually when the aneurysm is ruptured, they use this procedure. Or when it's very severe. And then the second one is coiling. They put a cathedral in your knee or in your muscle, and until they reach the nerves of the brain. So from here, they keep putting the cathedral until they reach the nerves of the brain, until they reach the aneurysm. And they keep putting coils inside it until it's full. Or depending on the case, sometimes they fill it, sometimes they don't fill it, depending on the case. So this is another way of coiling. What we want is to close the aneurysm so that it's, no blood goes inside it. This is the second one. The third one is stenting. Stenting is used when high velocity blood is going inside the aneurysm. So what we do is we put a mesh. This is a mesh. We put it inside so that most of the flow is diverted inside here. And small flow is going in here. Those are the 3 treatment procedures. Image, I'll talk now about image pre-processing and modeling. Basically what we do is the patient comes to the hospital, he takes an angiography image using the X-ray machine. It takes 3D images on layers, different layers, and then the working station gives us the 3D image of the aneurysm. This is the aneurysm. After that, after we get the image from the 3D angiography machine, we do something called truncation. Basically, we cut the part that we need. This is the aneurysm, this is the part we need. This is the parent artery, those are the sister arteries. So, and also we take measurements of the parent artery and the sister arteries and the diameter of the aneurysm. Whatever we want, we can get it. And this is the 3D CAD image. Basically, what we do is we reconstruct the image, because the quality that we get from the angiography machine is a little bit bad. So we use MeshLab, Blender, SolidWorks, and finally we use ANSYS to reconstruct the image and fix the topology until we get this image. Also, sometimes we use an approximated geometry. It's easier to use an approximated geometry. This is something that I drew. It is similar to a terminal type aneurysm. Basically, what I do is I get data from research of diameters of the arteries and the aneurysm depending on what I'm using. So sometimes we use this, sometimes we use the real geometry. Then we do a mesh study. Basically, for answers to solve the problem, you need to cut your model into small bits. And then the program will solve the equation on every element of the mesh. Also, we do something called a mesh independent study, so that we make sure our result is valid and our mesh is fine. Also, something that we put is the inlet velocity of blood. This is the inlet velocity of blood, systolic and diastolic. So basically, here we can see a maximum of 0.5 meter per second velocity, and then a minimum of 0.1 meters per second. So basically, this is the inlet velocity, a transient inlet. Sometimes we use a maximum velocity of 0.5 also, depending on our problem. This is also based on data from research. After we do the pre-processing, now the computer knows how blood will interact with the aneurysm. So it starts solving. We start the solution. We have a convergence criteria, 1e minus 6. And we keep solving until we get a convergence. When we get the convergence, we are sure that our solution is correct. So now I'll start with the first objective. It's called the validity of the Newtonian viscosity model assumption in CFD analysis of aneurysms. Basically, we have 5 patients from Tawam Hospital, data that we got from Tawam Hospital. What we do is that while reading research, we notice that researchers are using an assumption. This assumption we think is not valid. Basically, the assumption states that usually blood is a non-Newtonian fluid, but the assumption assumes that blood is a Newtonian model, is a Newtonian fluid. So they do this to make their life easier, to make the solution easier. So basically what we did is to put this on test on the 5 patients. As you can see, this is the Newtonian model, and this is the Carrera model. It's one of the non-Newtonian models. And we compare. We get some results. This is the velocity profile, the streamlines. As you can see, velocity is very slow in the aneurysm dome, and it's getting faster over here. So what we do is we compare between the streamlines, velocity vectors, and wall shear stress for the Newtonian model and the non-Newtonian model. This is our first graph, we can say. First of all, this is time with maximum wall shear stress. You have Newtonian model, non-Newtonian model, and this is the deviation. First of all, you can notice that the velocity profile is similar, the wall shear stress profile is similar to the velocity profile. This is the first thing we notice, because wall shear stress is dependent on velocity. So it's following the path of the velocity. This is one thing. Second, we notice that at maximum velocities, we have the minimum deviation. But at minimum velocities, we have the maximum deviation, which is the difference between the Newtonian and non-Newtonian model, which is a big difference, 45% difference. This alone can say that the Newtonian model is invalid, especially for low velocities. So this is one of our conclusions. We took 2 sample points at 0.1 and at 0.3 to study. This is the maximum velocity, this is the minimum velocity. At 0.1 seconds, we noticed that the deviation between the Newtonian and the non-Newtonian model is small. But only in the minimum wall shear stress it is big, because the minimum wall shear stress occurs at the lowest velocity. That's why it's big. Even though it's at the maximum velocity here, but the minimum wall shear stress is coming from the lowest velocity. And then here, at 0.3 seconds, we notice a big difference. This is the normalized data between wall shear stress of Newtonian and non-Newtonian. This is a Newtonian, this is no Newtonian. 1, 0.6, and here you have 1 and 0.5 for the average wall shear stress. Our conclusion from this study, first of all, the Newtonian model underestimates wall shear stress, especially at areas with low velocities. And then we concluded that it is not appropriate to use the Newtonian model assumption. And we decided to use the non-Newtonian model in all of our following studies. So basically, all our following studies from now is using non-Newtonian model. Our second study is the effect of cerebral aneurysms size on wall stresses and strains. You should differentiate between wall stresses, which is the shell stress, and wall shear stresses, which is the stress coming from the shear of blood with the wall. Basically, in this study, we used the approximated model. This is a real model. We used an approximated model. We noticed from previous research that the maximum wall shear stress occurs at the terminal point because flow impingments blood cells onto the artery wall. So this is an initiation for our study to study the initiation of aneurysms. Here you can see the wall shear stresses, and here you can see the velocity vectors. Basically, like what I want to tell you is that there's a maximum here. What we did is that we took the healthy artery, the one you saw before, and we took 8 different cases for different size aneurysms. So we started by the healthy artery until we reach 14 millimeter diameter. Using this equation, we get the aspect ratio, diameter of the aneurysm divided by the diameter of the artery. And the thickness of the aneurysm is from previous data, research data. We found the thickness of the aneurysm to be increasing with the increase of the aspect ratio. Okay, our first result is the deviation of deformation with aspect ratio. We noticed at the first part that as aspect ratio increases, deformation increases, but with a small rate. So we took this as a part of our graph. And the second part is the other part. So from 0 to 0.88 aspect ratio, we have this equation for change in length with aspect ratio. And from 0.88 and above, we have the other equation for change in length. This equation can give you like you can know about the deformation with the change in length. So you can just take the picture of the aneurysm, you know how much deformation you are expecting. And you can see here the deformation, and this is the before and after deformation. Another thing is the shell stresses, the von Mises stresses. Basically, we took the maximum von Mises stress for the aneurysm, and for the parent artery, and for the sister arteries, and we plotted them. And from research, we found the yield stress. We have the yield stress already. So basically, anything above the yield stress, this is the yield stress for the aneurysm. And this one is for the parent artery. Anything above it, you are expecting your aneurysm to rupture, based on our results. And the parent artery, this one, is not affected because whenever you enlarge your aspect ratio, it's not getting any effect. Unless, because the thing growing is the aneurysm, not the parent artery. This is the equation of von Mises versus yield stress. Basically, if anything above or equal to the yield stress, you are expecting your aneurysm to rupture. But of course, this is one criterion. You can use another criterion to be sure. One of our studies is the stagnant area ratio. Basically, the stagnant area ratio is the area that is stagnant, not moving, of blood inside the aneurysm. The green area is stagnant, the red area is moving. What we want is we want the aneurysm to occlude. And it occludes if the whole velocity is 0. But we notice at large velocity, at large aspect ratios, that the stagnant area ratio is 0.85%, or let's say 85%. Basically, this means that if you use coiling, your coil might go inside the aneurysm, which is called recanalization. So what we need is to use stenting to divert the flow, to reduce the flow velocity, so that the coil doesn't go inside to the aneurysm. Our conclusions. First of all, as aspect ratio increases, the wall shear stresses decrease. Then, as aspect ratio increases, the wall stresses increase. And the third one, that the relations that we derived, they could be used clinically to decide how severe the operation is, how should we do the operation now or should we make it later. So those the equations, they can be used by neurosurgeons. Our third study is the porous media simulation for endovascular coiling treatment. Basically, this is the aneurysm before you add coils, and this is the aneurysm after you add coils. What we want to know is, of course, they use coiling, neurosurgeons. We want to know how much coiling they should put and which coil diameter they should put. So we did our study using the porosity, volume of void, which is the empty volume, divided by the total volume. You can see here while the neurosurgeon is adding the coils. He keeps adding coils until it's filled or depending on his need. Okay, first of all, I would like to introduce you to the Navier-Stokes equation. This one is the one we use usually, but when it consists of the pressure, the acceleration term, and the viscous stress term. When we introduce the porosity, we have two extra terms, the Darcy term and the Forchheimer term. Those terms are affecting the porosity. So basically, from the equation, we see it's dependent on velocity. And because of that, our velocity is very little, 0.5 meters per second. It's very small. So we concluded that we can exclude it. The C term, we can remove it. So it's 0, because it's very small. And then we are left with the Darcy term. This is the relation of the Darcy term of the permeability with the coil radius and with the porosity. So from this equation, we know that this equation is for the mesh. For different shapes of aneurysms, you have different equations. And this is the Darcy equation with porosity and permeability. We concluded those tables. Of course, Dr. Waseem provided us with the coils that he uses and the radiuses of the coils that he uses. And then we plotted this graph for different coils with constant porosity. So you have this porosity constant. You notice it, it's constant. And the radiuses are changing in the ascending order. It's increasing. We got the viscous term and the permeability term. And we plot them in our model, in our program. Here, you have one coil with different porosities. Yani this one is one coil. But the porosities are increasing, 0.1, 0.3, 0.7, until 0.9. And we got our data. First thing is the flow rate with the porosity. The flow rate entering the aneurysm. Basically, as porosity increases, the flow rate increases. This is expected because our derivation, our equation for porosity, void divided by total. So as more void is available, more flow can enter the aneurysm. So this is expected, and it shows our results are matching equations. And here you see wall shear stress with porosity. As porosity increases, wall shear stress increases. We noticed that surgeons need to keep their porosity between 0.1 and 0.15, let's say. And then here, you don't have a big difference between if you keep the porosity here or here, 0.9 or 0.3. Why is this happening? Why is the wall shear stress increasing as porosity increases? Because when you remove coils from the aneurysm, you are having more free space for the aneurysm for the blood to interact with the arteries. That's why wall shear stress increases. And here you have Walsh stress versus radius. It's a small change. We notice that it's a small change, but as coil radius increases, area average Walsh stress decreases. But it's a small change. That's why porosity is more important. So the surgeon needs to keep his coil diameter at the maximum and the porosity at the minimum. Those are our conclusion. Porous media can provide guidance on the needed amount of coil stacking needed. Coil stacking is the inverse of porosity, but they use it as their terminology. So we use porosity. Large coil diameter produces lower wall shear stress and higher flow circulation. As you noticed in our previous diagram, it is recommended to use the largest possible coil as long as the porosity kept low at 0.1, for example. So this is the end of our third study. Our fourth study is the hazard effects of gravitational forces on aneurysms. Basically, some case studies reported that due to high decelerations, some aneurysms have been popping. For example, if someone had an accident, they notice that he has an aneurysm popping. Also, some people, when they use roller coasters, after they go out, they notice that aneurysms are popping. Same thing for people with high accelerations, for example, Air Force pilots. So we wanted to put this to the test. First of all, an introduction. Aneurysms oriented in opposite to gravity has a low risk of thrombosis. Thrombosis means تجلط. So it has low risk of thrombosis, this one, because blood is circulating and it's moving. But the one oriented downwards, it has greatest risk of thrombosis. And it is known from science that negative gravities concentrate blood in the upper regions of the brain. So if you're falling down, most of your blood is concentrated in this area. And the arteries in this area are very weak. They might rupture. What if you have an aneurysm? The risk of rupturing is more. So we put this to the test. Basically, this is a schematic of pressure for human body on normal temperatures. We have the average height of humans and the individuals in UAE is 1.7 meters. And then we have, from research, pressure at the heart, 13,000 Pascal around. You should differentiate between pressure at the heart and pressure of the heart, because heart is considered as a pump. It's a positive pump. So basically, we need to find the pressure of the heart. Using this equation, the gradient equation, for heart, this is the pressure of the heart, and this is the gradient, the weight of the blood on the heart, on this area. Using gravity, this is at normal conditions. So basically, using those two, and the location of the heart, here is H, we get the pressure of the heart, 10,241 pascals. This is the pressure of the heart. And then for the whole length, we find the pressures. What we are interested in is the pressure at the aneurysm, which is located at around 0.2 meters from the top of the head, which is 12,300. And then we start changing the gravities. But just notice now, pressure at the foot is like 28,000, around 28,000 Pascal. A big difference between it and the pressure at the aneurysm. But the arteries of the foot, they can withstand this pressure at normal conditions. We investigated 7 different gravities, from minus 3G up to 3G, including 0G. 0G would represent an astronaut in the space. Again, just to make sure everyone is on the same page, if you are falling downwards, you're getting negative gravity. If you're falling downwards, negative gravity, because all the blood is concentrated here. If you are accelerating upwards, blood is concentrated in the foot, positive gravity. And here you are the plots for pressure and height, with different gravities. First of all, we notice at 0G, you are not getting any change, because the equation only depends on the pressure of the heart. G is 0, so you're not getting any change. And this is the area of interest for us. The first thing we notice is that at minus 3G, we have very high pressures, 55,000 Pascal, which is humongous. For sure, an aneurysm will rupture at this pressure without starting all any data. And we notice also that negative G's, this is negative 1, and this is positive 3G. And we notice that negative 1G affects aneurysm more than a positive 3G. Which means if someone is having a negative 1G for a small period of time, he could have his aneurysm rupture, but we put this to the data test. Our first observation is that wall shear stress is not affected by G-force acceleration. Those are 5 different aneurysms at 0 aspect ratio and at 4.8 aspect ratio. It's not changing. You see, the acceleration is changing, but the wall shear stress is not changing for each one. It's constant. Why is that? Because wall shear stress is not independent of acceleration. It's just dependent on the velocity of the blood. Because the heart is a positive pump, so it provides blood at constant velocity. So it's not affected. We notice also that as aspect ratio increases, wall shear stress decreases, just like the previous study. Look, all the G's are similar, above each other. Those are the stresses and the strains. For G-force acceleration and stresses. Here, first one. Look at the deviation of the stresses for the positive gravities and the negative gravities. You notice, first of all, negatives are very high. And using our data, of course, this is a two-sided graph for 3 and for negative 3G. Using our yield stress, we notice that most of the aneurysms here, our yield stress is around 0.75. Most of the stresses here, most of the aneurysms here are rupturing. You can see any aneurysm getting minus 1G, it will rupture. All of them, those are rupturing. But the positive G's, most of them are not rupturing. So this means negative G's are more severe. And here, of course, you can see aspect ratio with stress, and similarly, strain with G-force acceleration. And those are contours of wall shear stress and stress. So conclusions: as acceleration increases, the blood pressure increases, as you notice in that figure. But negative G's have more effect than positive G's. And also we notice that wall shear stress is independent of z-axis acceleration, like we also noticed in our graph, because it's provided from the blood, constant velocity. Negative G forces can cause more hypertension, high pressure, and wall stresses, which is shell stresses, than the positive G forces. This is one of our conclusions. So subjects with aneurysms should avoid negative acceleration. They should avoid roller coasters and high decelerations. So now the conclusion of my presentation. First of all, the specific reason for the rupture of the aneurysm is ambiguous. We don't know, but we can tell you some risk factors. And many risk factors have been determined by doctors, medical doctors. But using our scientific simulations and our engineering assumptions, we give them more risk factors like wall shear stress and shell stresses and strains. Basically what they do is they consider the age, they consider if he's smoking or not smoking, they consider the family history. But here you have more data to compare. Just from seeing the aneurysm and knowing the aspect ratio, you can know if it will rupture or not. What's the deformation? Should we do the operation now, or should we make it tomorrow or after tomorrow? It depends on the surgeon. And our progress in computational modeling, it can be applied to common clinical problems like the cerebral aneurysms. Some recommendations. First of all, we recommend using real patient-specific geometry always. You saw that sometimes I used approximated geometry. But we always recommend to use real patient-specific geometry, because Every patient has a different shape of aneurysm. And aneurysm is very sensitive to changes in geometry. It's very sensitive to that. So it's better to always use them. Why we did it? Because it's easier and it's faster. Extract the best quality images. You saw that I used around 5 programs to reconstruct the image. This is because the image is not very clear for me. So it needed reconstruction. So we need more like high advanced angiography machines to take better pictures. Processing time should be faster for clinical purposes. When I introduced the porous media equation, my equation got bigger. And it took me around 2 days to solve for one case. For one case I want to solve, it takes 2 days of processing. So basically, what a neurosurgeon would need is something faster. Because the patient comes, you take the picture, you need the data to be ready. And to know when your operation can be done. So processing time should be better, either using high processing computing, or depending on, maybe you can use your own program, which is faster. Measuring the blood flow conditions on patients. Remember the blood flow, the systolic and diastolic? This is from research. And every patient has a different blood flow. So also any patient with hypertension, they would have different flow conditions. So you should measure the blood flow for every patient and also standardize your definitions. A lot of researchers use different definitions for their when they start writing. So we get confused. Everyone like names aspect ratio differently. For us, it was the aneurysm diameter with the artery diameter. So we need the standard definitions so that we compare apples to apples. Our future directions, basically we are working on more porosity studies, and we are considering studying stenting and when it should be applied. Also some sensitivity studies like the effect of truncation. For example, you saw how I cutted the aneurysm. How much artery should I keep? How much artery should I cut? This is a sensitivity study that we are thinking about. Some of our publications, we published 1 conference paper, and we submitted 3 journal papers so far, and we were working on the 4th journal paper. So our work has been very fruitful. I'd like to thank you.
Okay. So thank you, Hashem, for the presentation. Now we can have questions from the audience before we start the defense. So the audience, if you have any question. Especially the PhD student, the master student, have to ask questions. Mechanical engineer.
Actually, I have a question. One of the first things that you said is generally we assume blood to be a Newtonian fluid, but for the purpose of your model, you tried non-Newtonian fluid. So is that just for brain flow, or is that generally used throughout for all veins?
Okay. What I looked at is blood and brain flow. But for example, blood is known to be non-Newtonian. So why researchers in cerebral aneurysms are using it as Newtonian? Because it's easier for them. That's the only reason. I think researchers that study the heart would consider it the same thing. It's easier for them to model blood as Newtonian. But for us, we have an area with very low velocity, which is the area of the aneurysm. So we need to make it non-Newtonian, because the Newtonian model just considers one value, but the non-Newtonian model is different at every velocity value.
So usually at high speed, Newtonian would be fine, but as you said, the small artery that they have in the brain and the
Underestimate or overestimate?
Sometimes underestimate, sometimes overestimate.
For low flow?
Low flow, underestimate.
Newtonian underestimate.
Yes.
So it's higher than
Yeah.
Is it regarding time or regarding
Regarding systolic and
time it takes to process them?
they mean
Computer to
yeah.
compute?
Around 2 days.
the porous.
The porous.
No,
Others
no,
they need
but
to take.
Newtonian,
It's more time.
It's more
for
time.
computer.
If you talk about like strong computer, the one he used, it doesn't make a huge difference in the time. But if you single processor, it will make a difference.
I
This is the pump of the pulse of the heart, like this. So basically, at the systolic, it goes like this, maximum. Diastolic, it stays the same. If you're asking how it's changing in the model and the computer, what we do is instead of having a steady study, we do a transient study. So it's different than the steady study. Steady study, you just put one velocity. The transient study, you have this profile of velocity. It's a user-defined function. You use it, and you have time steps. At every 10 time steps, for example, at every 10 time steps, give me data. 10 time steps, give me data. It keeps giving you data at different time steps, and then you can compare between your data.
So it can change.
It can change. How do you mean?
I mean, by head.
Yeah. Yeah, if you measure the real patient, it will change, of course. It's different than this. For example, if you have a high pressure, this will be it will shrink. You know?
So what is the heartbeat for this diagram?
This one, I think 120 pulse per minute. So this is the average. We're using just average pulse. Some people have more pulse, but we are using average for our purposes. But for the doctor to use, he should use the real one.
And we can have one more question. Anyone has a question? So I'll ask you just one question and we'll finish with this. So you're using one-way FSI model. What's one-way FSI model?
Okay, for the fluid structure interaction study, the one we did for the growth, we found the wall shear stresses and the shell stresses. Basically, I wish I can show you a picture, but you solve the fluid analysis, and then you send it to the stress analysis. This is called one way. Solve the fluid and then send it to structure. But the two-way analysis, because the growth is at real time, because it increases, the aneurysm grows, and blood circulates more. Instead of just solving blood velocity and then putting it in stress, the two-way keeps solving back and forth, until you reach a convergence. So it iterates. This is the difference between one way and two-way. What we use is one way, and this is one of our limitations, as mentioned in our thesis, because I was not able to do the two-way one.
Okay, thank you very much.
Thank you.
Thank you.
So now we'll have a break. I mean, for guests and for you, you can drink or eat something, and then we'll hold the defense after 15 minutes. Okay, so after 15 minutes is break, then you proceed.
Before the break, I want a picture with my advisors and my father.
I can do that. So, Dr.
Yeah.
the main examiner.
دكتور صورة على السريع.
Yes.
You need the picture.
لا.